Welcome to Cardio Radio, a podcast of the Ohio Cardiovascular and Diabetes Health Collaborative, also known as Cardio. This is Dr. Michael Constant from the Case Western Reserve University School of Medicine, and I serve as the principal investigator for Cardio, a statewide network of Ohio's 7 medical schools. Cardio is funded by the Ohio Department of Medicaid and shares best practices to improve cardiovascular health, diabetes outcomes, and to eliminate health disparities in Ohio's Medicaid population. The opinions and recommendations in this podcast are those of the presenters and not those of Cardio and its sponsors, and are not intended to be a substitute for medical advice. I hope you enjoyed today's podcast.
Hello, I am Dr. Ryan Farrell, an associate professor of pediatrics at Case Western Reserve University in Cleveland. I'm a pediatric endocrinologist and a member of Cardio's Team Best Practices. I'm here today with Dr. Kathleen Dungan, professor of medicine and adult endocrinologist at The Ohio State University. She also happens to be the co-lead for Cardio's Team Best Practices. In addition, we have a very special guest today, Miss Sylvia Quinones, a student at Hiram College and patient of mine who has been living with type 2 diabetes since she was 13 years old. In today's podcast, we will review the evidence for use of continuous glucose monitoring, or what we'll refer to as CGM, in patients with type 2 diabetes. We'll also discuss the potential barriers to uptake of CGM among specific populations, and we'll illustrate approaches to promote implementation in clinical practice. Then finally, we'll hear from Sylvia directly about her experiences with this technology. So welcome, Kathleen and Sylvia.
Thanks, Ryan. It should be a great discussion.
Thank you. It's great to be here.
So Kathleen, what exactly is the evidence for use of CGM in type 2 diabetes?
Most of what we know about type 2 diabetes is actually derived from studies of people who have type 1 diabetes. This has become the standard of care for type 1 diabetes because of its fundamental role in helping patients achieve their goals for hyperglycemia, hypoglycemia, and also now emerging data that CGM reduces the risk of hypoglycemic events that lead to hospitalization and also hospitalizations for diabetic ketoacidosis. In a recent meta-analysis of 26 randomized studies involving 2,800 patients with type 2 diabetes, continuous glucose monitoring did show modest reductions in A1C of about 0.2 to 0.3%. And this doesn't seem like a whole lot. However, there's a lot of variability. So, for example, in a systematic review of 4,000 patients in the primary care setting, there were 10 studies that reported, and there was an estimated mean difference in A1C of about 0.4%. But those patients who wore the device consistently and those patients who were on multiple injections of insulin saw bigger changes in A1C. So greater than 1% reduction in A1C in those individuals who had a baseline A1C of 9% or more. So it's important to note that the types of patient populations and how they use the device is going to influence what kind of benefit they will achieve. Importantly, these A1C reductions are achieved without the need for additional medications. And so primarily, these are achieved through changes in lifestyle. People with type 2 diabetes who are not using multiple injections of insulin per day are generally less likely to experience hypoglycemia, and thus they are less likely to receive hypoglycemia benefit than in persons with type 1 diabetes.
Thank you. It's also reassuring that CGMs can seem to be employed both in primary care practices as well as in specialty clinics. For those patients who are not sold on wearing a CGM for the long term, is there any potential benefit from using it even just temporarily or just sort of intermittently?
Yes, in fact, there are some data that demonstrate that intermittent use, such as using a sensor once a month for 10 to 14 days, can offer potential benefits. And also the use of a blinded CGM, which is otherwise known as professional CGM, can also provide some benefits on the order of A1C reduction of about 0.5% in persons with type 2 diabetes who are using insulin. The one caveat here, though, is that ongoing intermittent use shows better results than just a single one-time use.
Well, at least it's beneficial to hear that there's some benefit in wearing it intermittently. Are there any consensus guidelines or expert recommendations for the use of CGM?
Yes, this is a continually evolving set of recommendations, but in the most recent American Diabetes Association standards of care, CGM is recommended in persons who are using insulin and generally assigns a higher level of evidence for real-time continuous glucose monitoring versus the intermittently scanned devices. CGM is also recommended for youth with type 2 diabetes who are using multiple injections of insulin, and also based upon expert opinion, as we really don't have a lot of evidence in youth. And finally, in those individuals who are not using insulin, there's less evidence, but there are some emerging data in terms of at least one randomized controlled trial and a cohort study that was done retrospectively.
Wonderful. Thank you. We certainly know that in the realm of diabetes that there are certainly social disparities that exist, and certainly these disparities impact the ability to achieve glycemic goals. What about in the use of CGM? Are there disparities in certain social settings for CGM use as well?
Well, this is certainly top of mind for cardio, in which one of our main goals is addressing disparities. And so there are some studies actually showing that CGM use is lower in individuals self-reporting as Black, Latino, compared to white Americans with type 1 diabetes. There's less available with type 2 diabetes. However, there's a single center study in persons with type 2 diabetes that reported some disparities by payer status, but not necessarily among self-reported racial and ethnic groups. So the reasons for these disparities, nevertheless, are complex, and this could range from implicit bias factors to language barriers to just access to quality of healthcare. And at the provider level, there are other factors that might include just the willingness to prescribe with the complexity of prescribing. There is questions of ability to implement shared decision making. In both patients with type 1 and type 2 diabetes, primary care providers tend to be less likely to prescribe than specialists, I suppose, not surprisingly. And then, interestingly, if you can remove some of those barriers, in particular, one example is that Colorado Medicaid and also actually Ohio Medicaid removed a lot of the barriers to obtaining continuous glucose monitors in terms of the prior authorizations. In the case of the Colorado example, they published really nice data showing that fully subsidizing CGM can eliminate these barriers and the disparities associated.
It's really great news to hear, especially here in Ohio, where we finally do have good coverage for CGM use for all of our Medicaid patients. What kind of barriers are there with other payers?
Each insurance company has somewhat different steps, and so this can be quite a challenge on the part of the prescriber to be able to navigate, and also by extension on the part of the patients. Some insurance companies, including the traditional Medicare plans, require that a prescription of sorts be sent to a durable medical equipment company. This requires generally a different process and a certificate of medical necessity. Usually it involves sending office notes, and these are all workflows that for most providers falls outside of the typical electronic medical record workflow. So you're faxing, you've got these papers that are kind of going back and forth. And for others, the prescriptions can be sent to their pharmacy. For many Ohio Medicaid patients, that is the case. But if it's inadvertently sent to a pharmacy and it's not covered, sometimes they don't actually know to tell the patient that they have to go through a durable medical equipment company. And sometimes, even if they can go to a pharmacy, there still might be a prior authorization process. Payer barriers are known in general to disproportionately affect Black and Latino patients, so this is a concern. We also know that it's a concern for physicians. In one survey, 92% of physicians stated that prior authorizations in general delay treatment and impact health outcomes. Most of the physicians indicated that it can lead to abandoning treatment at least some of the time.
Yeah, I can speak personally that the variations in all these different insurance processes are certainly one of the biggest barriers for my patients and for people that I know that are also prescribed these CGMs. Are there any resources for healthcare providers to help assist with obtaining access for their patients?
Yes, in fact, there are several resources that can be very helpful. For example, the Association for Diabetes Care and Education Specialists Dana Tech website. That's located on our webpage if you want to check that out. This contains some resources to help support clinicians to kind of keep updated on which payers cover CGM and what kinds of requirements are necessary. There's another resource called diabeteswise.org. And that's where clinicians can use the tools to determine which CGM system's right for their patient. Now, there are some platforms that are currently becoming more widely used across institutions. One example is called Parachute. And these will streamline the prior authorization process and make it more electronic. And there are ways to actually integrate many of these systems within the electronic medical record. Some of these require a subscription, however, and cooperation with your institution's information technology support. There might be a need for legal agreements. However, when you consider the cost of personnel and sort of managing all of these forms and the patient satisfaction, the costs may be worth the investment.
Are there any other tips that you would recommend to overcome access barriers, Kathleen?
Oh, definitely. I would consider at your institutions, if not already, raising awareness about some of these barriers, including the possibility of unconscious bias, and educate the healthcare providers. There's a really nice example published about a year ago where at an academic medical center, they did this as part of their process to improve access. I would set expectations for patients on some of these timelines, which, because of the need to process paperwork, can be quite lengthy. I would, make sure that there's a direct line of communication potentially with one or two of the suppliers and potentially involving manufacturers in helping to kind of overcome some of the barriers. And it's helpful to have a point person, especially if your volumes are high enough. At some practices, pharmacists really fill that role and do a great job. There are other things that can improve workflows too, like creating pre-filled order panels and creating preference lists to kind of help simplify that ordering process.
Okay, so I have a patient, they have their CGM device in hand, but there's just so many other things that seem like they kind of get in the way. Things like, the technology or whether or not it's compatible with their phone, all these different types of things. How can I help, to implement CGM use, practically speaking, in my practice?
Well, first, you want to think about what is the right device for the right person. And that might involve the location of wear, the duration of wear, how they want to receive their alerts, and how they can share data. The Cardi-OH website has some additional resources related to CGM that you might check out. Whenever possible, I like to make sure that the device is compatible with the patient's smartphone. And so we're finding that a lot of times the patient may have a smartphone, but really the device isn't compatible. So they do have to use the reader. You can usually look this up on the website for each of the devices. The manufacturers usually do a pretty good job of keeping those up to date. And then also consider using a team-based care so that your staff are aware of how to implement CGM, even at the point of care. Be able to download reports and linking them to the clinic accounts can save a lot of time. And this will facilitate future visits and potentially even remote monitoring. Manufacturers or key personnel can help with this onboarding and maintaining access and knowledge. in addition, the diabetes educators or other types of nurse specialists can help with this process. Billing for initial CGM training and placement is covered by many plans, and interpretation of CGM reports is also a billable procedure up to once per month. And this is with or without an office visit. So this can offset some of the staff time that is required to assist with the setup of CGM. So there are some intermediary platforms that can also help integrate the reports into the medical record. There may be subscription or setup fees for these types of platforms, but it can speed up the access to the reports themselves. Finally, including education on what types of alert thresholds are available, what kinds of troubleshooting a patient might want or need, and just setting them up for expectations as far as how accurate that sensor is. I think that's one of the biggest questions that a patient has, especially if they're already doing fingerstick glucose monitoring. And then just how to treat high and low sugars, and especially if they're requiring insulin.
So it's really good to hear of the many different ways that doctors' offices can overcome a lot of these barriers for successful implementation of CGM by their practice. But it's important to appreciate the patient's perspective as well on starting to use CGM. It's a really big transition for your practice, but also for your patients. And so we're going to turn to our special guest, Sylvia, who has been using CGM now for about 3 years. Sylvia, welcome again. When you started to use CGM a few years ago, what challenges do you recall kind of facing, at least initially?
Thank you for inviting me. I'll say that I'm very glad to have made the transition to my CGM. It's more convenient for me to use, and it's more beneficial for me to see the values of my glucose in real time. I feel so much better understanding my diabetes and my glucose levels. However, when I did first start using the CGM, I did encounter several different challenges.
Okay, so let's discuss each of these challenges one by one. First, how did it feel physically to wear this device all the time?
It was extremely different to have something on my body, 24/7. At first, I was nervous I was knock the device off. I was hyper aware of the device and its location on my body. But over time, it becomes less noticeable, and I like not having to stick my finger and carry my monitor and test strips. Now, I don't even think about it with the device, and I can focus on work and other activities, knowing that the devices will alarm me if my glucose is trending too low or too high.
Yeah, and then tell me about the alarms, because that's certainly a source of frustration for a lot of people that wear CGMs. And I think we all kind of are aware of this concept of alarm fatigue. Tell me about those kinds of things that you've run into.
So it did take me a bit to get used to set alarms, but it is important for me to know when my glucose levels are on low or highs, and it's especially important for my physician to know. For me, I wanted to know when the glucose was less than 70 for my lows. This gives me time to pull out my glucose tablets or my juice box before I have any symptoms. It's all about the safety, guys. For the high glucose alarm, I first had it set to a higher level, then lowered my target over time as we adjusted my medications.
You're right, Sylvia. Safety is definitely important. Now, some patients, have issues with things like sensitive skin, and the skin can get very irritated under or around the sensor, and that can sort of impact, the itchiness and willingness to use the sensor. Did this happen to you at all?
I didn't have a lot of skin irritation, but I did have issues with the monitor sticking for the full duration.
Yes, skin irritation and adhesion are both very common issues. So, at least in my practice, we have some tricks that can help patients who have sensitive skin. Things like using some over the counter fluticasone nasal spray. This is a spray medication that decreases inflammation in patients with asthma or allergies, but you can spray on the skin where you place the CGM device. It dries pretty quickly without leaving a whole lot of residue, and it can prevent, skin irritation and inflammation as well. And then for adhesion trouble, there's several different products, things like skin tack that you wipe on the skin to create a sticky surface before placement of the CGM device. And then this adhesive tends to be hypoallergenic and latex free. And there are also patches that can be placed over the device to help them stay in place as well. So my last question for you, Sylvia, is how did you feel about seeing all of these glucose values. It's a lot of information that just gets thrown at you continuously, hence the C in CGM. Was it data overload for you at all?
It was certainly a lot of information. At first, I was shocked about the ups and downs of my glucose levels, but after a few weeks, it helped me adjust my eating habits and my medication doses so that when the glucose values were more stable, I felt better. The alarms happened less frequently and my glucose values were steadier. I felt physically better and felt better about my diabetes.
Well, that's really great inspiration for others that may be just starting the process of transitioning over to CGM. So thank you very much. I'm glad that you could join us today. So again, we can conclude that CGMs can help patients achieve their glycemic targets, with the largest clinical benefits observed with long-term continuous use of CGM. Ohio Medicaid covers CGM for patients with diabetes. Successful implementation of CGM occurs through awareness of clinic and patient level barriers and strategies, as discussed, to address these barriers. So Kathleen and Sylvia, thank you again, both of you, for joining me today.
Ryan, thank you for having me.
Yes, thank you. It's been a pleasure.
And a special thank you to you, our listeners, for tuning in to Cardio Radio.
This concludes today's podcast. Be sure to visit cardio.org to learn more about the Ohio Cardiovascular and Diabetes Health Collaborative.